Hello, everyone, and welcome to our webinar. We are excited that you're here, and we are going to be talking about the guideline for the implementation of enhanced recovery after surgery. And also, we are going to be discussing our newest Center of Excellence, Enhanced Recovery After Surgery. And I will be joined by my colleague, Hannah Campbell, who is the program manager of the Center of Excellence. And I'm Dr. Lisa Spruce. I am the Senior Director of Evidence-Based Practice for AORN, and I was the author of the Enhanced Recovery After Surgery Guideline, which really focused a lot on implementation. So I'm going to sort of just go over some of the really important aspects of that guideline before turning it over to Hannah to talk about how you can become an ERAS Center of Excellence. So most of you know probably that ERAS is an interdisciplinary program. It's an interdisciplinary approach to surgical care that aims to optimize patient outcomes and accelerate recovery following surgery. And I discovered my own ERAS experience when I had to have surgery for a torn rotator cuff. And I went to a small outpatient surgery center, probably had about 4 ORs, and they ran an ERAS program. And so I got to experience it firsthand and to see how great my recovery was, and then realize that ERAS really is for all patients. It's not just for patients having certain surgeries, but it is for everybody undergoing even a minor procedure. So it was really a great experience. And these protocols, they really aim to minimize the patient's physiological stress in response to surgery, that physiological response. And we describe in the guideline the methods that need to be implemented to minimize that stress response. And again, this guideline is focused on implementation. We do not give guidance for specific procedures. However, the ERAS Society does have procedure-specific guidance that you can access. So a comprehensive ERAS program does consider every step of the patient's experience, starting from the moment that they're referred for surgical care until their ultimate discharge. Now, while each individual care element may not yield substantial benefits when examined individually or independently, their integration with other components of this treatment process is believed to have this powerful synergistic effect. Now, this guideline was based on a systematic review of the evidence, and it is highly, highly researched. And there is a lot of studies that promote the benefits of patients undergoing an ERAS program. And I just want to highlight a few of those. So reducing complications like surgical site infections, promoting a faster recovery, promoting a shorter length of stay, improving patient satisfaction, reducing morbidity rates, improving functional recovery, decreasing opioid consumption, reducing pain, decreasing intraoperative blood loss, reducing the incidence of post-op nausea and vomiting, and decreasing patient depression and anxiety. And I forgot one, decreasing costs, very, very important for many of our organizations. So ERAS programs are developed and overseen by an interdisciplinary team. This team is led by an ERAS coordinator that's designated by the organization, and they have the expertise and authority needed to lead the program. And you can see on the slide all the professionals that are involved in an interdisciplinary team that are really important to include. And you can look at this list and then you can sort of think about maybe others in your organization that could be included, like a pain specialist or other specialists like educators and leaders. So whatever person you want to include is great. Now I just want to point out the role of pharmacists in an ERAS program. So their role is to optimize medication management before, during, and after surgery. And then we've included nutritionists here because incorporating nutrition risk screening into ERAS programs is really crucial for gathering vital information about patients who may be at nutritional risk. This screening helps to identify the need for nutrition, resources, and care. And it really gives you some insight on how nutrition risk can affect adherence and outcomes with ERAS programs. Patients who do screen positive for a nutrition risk we would promptly refer them to a registered dietitian or nutritionist for a thorough nutrition assessment. There is a table included in the guideline that talks about implementation strategies that include actions perioperative teams can take to promote a successful implementation because it does require careful planning. It should be based on a standardized implementation science strategy. So that's some things in the guideline that you'll see there. But a common obstacle that I saw in the literature was the variation in care driven by physicians' strong personal preferences. And some programs have successfully navigated that challenge by involving physician leaders and representatives from various disciplines to develop and advocate for key elements of protocols. And by basing these protocols on the best available evidence, organizations can maintain that sense of impartial objectivity and shift that focus of discussions toward the patient's well-being and away from historical provider preferences. And also, if you have a structured electronic health record order set, that's great because that can help reduce variability and guide clinical practice. Now, ERAS can be safely and effectively implemented in inpatient and outpatient surgery settings. Like I said, I was in an ERAS program in a really small outpatient surgery. They successfully had an ERAS program led by one of their anesthesiologists. Things you want to think about though is while a shorter length of stay is a key indicator of success in inpatient ERAS programs, it may not hold the same importance in an ambulatory setting. So instead, the focus of ERAS programs in ambulatory should be reducing variance in other patient outcomes to enhance overall quality of patient care. And these can be things like reduced pain, minimization of opioid use, reduced incidence of post-op nausea and vomiting, and then same post-discharge post-op nausea and vomiting, early ambulation, improved quality of recovery, and improved patient satisfaction. So you want to implement a standardized clinical pathway because that allows the entire perioperative team to systematically manage the patient's care, reducing variability and optimizing predictable outcomes. The standardized clinical care pathway should include considerations that are foundational to ERAS, and I'm going to talk about these in the ERAS phases of care. But before I do that, I want to just mention a couple of things, and these are the perioperative nursing roles. And we can serve as many roles in the ERAS program. That ERAS nurse coordinator is one of them, which I mentioned. And this person is a pivotal figure within the interdisciplinary team. They take on responsibilities such as planning meetings, working directly with ERAS champions, collecting data, communicating with leadership, actively advocating for ERAS principles among perioperative teams, and they really want to focus on enhancing compliance in daily clinical practice, because that's going to be really important. They can also serve as a patient liaison. And another role is the nurse navigator. And the nurse navigator acts as that central point of contact for patients and their families. And it provides them with information, support, and guidance throughout the entire surgical journey, from pre-op preparation to post-operative recovery. And then perioperative nurses, we are the ones that are creating guidelines for patient education. We're designing and implementing plans of care throughout the perioperative care continuum. We conduct the preoperative counseling, we conduct education, we prepare the patient for discharge, we provide in-hospital care and post-operative monitoring, which may include post-discharge follow-up through phone calls, text messages, or even visits. Now, the phases of care, ERAS is divided into 4 phases of care, and I'm going to talk about the highlights of each one of these phases of care. And then in the guideline, you're going to get lots and lots of details on each phase of care and the research that surrounded the recommendations. So first is the surgical optimization or prehabilitation phase, and this refers to the process of optimizing a patient's physical and mental health before surgery. In the literature, we found the terms rehabilitation and surgical optimization to be used interchangeably, so you may have heard either one of those terms. The goal here is to identify medical complexities and risk stratification and enhance a patient's ability to withstand the stress of surgery. And it also will minimize complications and improve patient recovery. And these are usually things like we do an individualized patient assessment. And you can also do screening. So these can be things like frailty screening, cardiopulmonary exercise testing, anemia identification, nutritional assessment, unhealthy lifestyle behaviors, identifying those such as smoking, and cognitive and psychological assessments as well. And you want to optimize those modifiable comorbidities in this process. So, even telling a patient to, stop smoking for 4 weeks, start walking every day for 30 minutes for 4 weeks. Even those little things are going to go a long way with improving their outcomes after surgery. And for most patients, minimal testing is necessary, but focused risk-based assessments can be implemented based on the patient's history and their comorbidities. And in the guideline, we have a lot of risk assessment tools that you can use that we found in the literature, so you don't have to reinvent the wheel. You just use one of these risk assessment tools. They're great, and you're going to use those based on what you discover taking the patient's history. And again, these programs may include exercise programs, nutritional therapy, screening and managing anemia, because patients with anemia are at increased risk of experiencing complications like infections, longer hospital stays, and increased morbidity and prolonged recovery. And anemia is an independent risk factor for mortality complications following surgery. So it's really good to make sure people are not anemic, and if they are, we manage that before their surgery. And then education and counseling is really an important part of this multimodal surgical optimization process. Patient education is important and it's shown to be beneficial for patients, and it certainly doesn't cause any harm. It also serves as a foundation for effective communication and empowers patients to actively participate in their own care. Educating patients on their surgical optimization we, is where we provide them comprehensive information on their surgery, on different analgesic options that they may be getting, and also establishing practical post-operative pain expectations that can potentially reduce patients' pain and reliance on opioids. Now, we also may include psychological interventions, teaching patients who are nervous about their surgery how to do deep breathing exercises or muscle relaxation or meditation or any of those things. I've seen facilities use the inhaled essential oils with some success. You can also teach problem solving skills and how to cope with the idea that you're going to have surgery. But these can really play a crucial role in alleviating distress for the patient, reducing anxiety, depression, and fatigue. So those are all great ideas for the pre-optimization phase. Now, there are a lot of things that go on in the preoperative setting. This is where you start planning to implement a multimodal pain management plan that can include regional anesthesia in the preoperative phase of care. This is where blocks are placed usually. We're giving education about pain management strategies here. And it's important because, again, patients need to understand about how their pain is going to be managed, what their goal, that the goal is going to be used to use less opioids, and they need to understand that they're not going to be pain-free. There is going to be some pain, but there will be a plan in place to manage that pain, and we sort of talk about what is that pain management plan going to be. Now, it's really important that we talk about these fasting guidelines, because when I had my surgery, I was very worried that they were going to tell me, don't eat or drink after midnight, when my surgery wasn't until 2 p.m. And so that's not a good strategy. But prolonged fasting is not good for patients. So they should be reduced, and fasting guidelines should be given according to the American Society of Anesthesiologists fasting guidelines. And for children, adults, and older adults, that is clear liquids up to 2 hours before your procedure, and light meal is up to 6 hours before your procedure. So not arrival time to the hospital or the facility. It is procedure time. So you want to make sure they understand that they can drink clear liquids. And it's really going to be much better for them to be hydrated when they come in for their surgery. And then you sometimes will see oral carbohydrate containing clear liquids being given to patients 2 hours before the procedure. Now, diabetic patients might be different, but healthy patients can have a carb loading drink 2 hours before their procedure, and that again is very beneficial for them. Prevention of surgical site infections is an important part of an ERAS program, and this usually is going to come in the form of preoperative antibiotics. There was a lot of great evidence that supports this. To effectively prevent SSIs in some patient populations, it's usually an IV bolus being administered 0 to 60 minutes before a skin incision. An optimal timing range is 15 to 30 minutes, and the type of antibiotic is going to vary depending on the intended procedure and the patient history and allergies. And there's some great guidance in the guideline. If you need more information on antibiotic therapy, that's in there. And then implementation of an SSI prevention bundle, which includes having patients shower or bathe the night before their surgery with CHG or soap, performing nasal decolonization if indicated, avoiding hair removal, and if you have to do that, use a hair clipper instead of a razor to remove hair, and then performing preoperative surgical site skin preparation with an alcohol-based antiseptic unless contraindicated. Assessing patients for the risk of venous thromboembolism and bleeding is important. This is where we implement VTE prophylaxis measures, which may include pharmacologic and mechanical interventions. Very high quality evidence supports the use of like compression stockings or some kind of mechanical device and low molecular weight heparin in all cases where the individual risk of thrombosis exceeds the risk of bleeding. And we do have a guideline for the prevention of venous thromboembolism, which has detailed guidance on screening and interventions. Now, patient warming is going to begin here, and we want to start it in the pre-op phase and maintain that normothermic state throughout the perioperative patient experience because there is a lot of evidence that this reduces the risk of postoperative complications. And I think we do this with varying amounts of success. I think we're usually great at getting it started, but whether or not it gets continued sometimes is iffy. And it's very important to continue it throughout the whole thing and monitoring the patient's temperature, because if you don't know what their temperature is, you don't know if they're normothermic and what interventions you need to implement. And then you want to assess risk of post-op nausea and vomiting. We know how that is such a very bad side effect for patients. You want to start this in the preoperative period and use multimodal prophylaxis based on that risk assessment. An effective post-op nausea and vomiting prophylaxis is based on a multimodal intervention using pharmacologic therapy, also avoiding fluid overload, and limiting preoperative fasting, and also making sure patients are getting up and moving after surgery and avoiding opioid use. Now, administering sedatives before surgical procedures, we see this sometimes. This actually can have a negative impact on a patient's postoperative recovery. So instead of relying solely on medication, it can be more beneficial to focus on effective communication techniques, such as just having conversations with the patients, making sure you've done some educational sessions with them before their surgery and providing psychological support. And this approach has actually, in the research, has shown to have better outcomes and improves the patient's experience than sedating them. Now we go on to the intraoperative phase. There's a lot of things happening in this phase as well. I talked about the importance of normothermia here and monitoring and maintaining the patient's temperature, making sure we're monitoring temperature throughout the intraoperative phase. And also this is where anesthesia professionals will be implementing interventions for a goal-directed fluid therapy. And this is tailored to each patient for fluid management and making sure we don't give them too much fluids or don't give them enough fluids. We maintain that euvolemic state by balancing maintenance and fluid and volume replacement therapy. And it's really important here to know that this is where patients are going to continue that multimodal pain management protocol. That's really important because the pressing demand for action against the opioid crisis in the United States highlights how critical this issue is. To address the problem of postoperative prescription opioid usage, it's imperative to implement interventions that are not only highly effective, but also free from unintended adverse effects. And they're most effective when we do it collaboratively. So with our nurses, our pharmacists, our surgeons, our anesthesiologists, and our patients. So the patients understand what their pain management plan is going to be and why we want to minimize the use of opioids. Now, there is a new act that came out and began being implemented in January of 2025 called the No Pain Act. and Congress enacted this. It stands for Non-Opioids Prevent Addiction in the Nation. The act passed on December 29th, 2022. And they had this act in order to minimize financial barriers to the provision of branded non-opioids to Medicare surgical patients for improved management of post-surgical pain. So the law expands patient and provider access to FDA-approved non-opioid pain management approaches to all outpatient surgical settings starting in 2025. It started in January. It requires a report to Congress on limitations, gaps, barriers to access, or deficits in Medicare coverage or reimbursement for therapeutic services. So you'll see this being spread across all facilities, and then there will be more access to insurance coverage of non-opioid types of pain management. So that's a really good thing that has happened. Now let's talk about multimodal pain management techniques, because ERAS protocols rely heavily on this to effectively manage their patients' pain. So you want to target various physiologic pathways, and the aim is to optimize pain control while minimizing the adverse effects associated with the narcotic pain medicine. And this approach can be employed throughout the entire perioperative process. Again, like I said, starting in pre-op, where many of the blocks are placed, and then just continuing throughout the perioperative period, extending into inter-op and recovery. And these often include strategies for proactive scheduled administration of non-opioid pain medicine for a period of time after the procedure to avoid pain crisis and rebound overdosing. And medication and techniques that are often used that you might be familiar with as well are things like NSAIDs, so your nonsteroidal anti-inflammatory medicines, your acetaminophen, regional blocks, local infiltration analgesia, spinal or epidural analgesia, liposomal bupivacaine, muscle relaxants, topical anesthetics, and then non-pharmacological techniques like even just ice or heat. They are great to help with pain. And then there's all these other things like aromatherapy and music therapy and biofeedback and hypnosis. So there's lots and lots of things we can use. And this is just a small number of multimodal pain management techniques. There's a whole bunch of these listed in the guideline that you could choose from to consider using with your patients. Now, the field of surgery has experienced a remarkable revolution thanks to minimally invasive techniques, and we're all grateful for this. It's led to numerous advantages for patients, including reduced intraoperative complications, decreased blood loss, improved postoperative pain management, shorter hospital stays, better cosmetic outcomes, and faster recovery to normal functioning. So it is increasingly recommended to opt for minimally invasive approaches such as conventional laparoscopy, the use of low pressure pneumoperitoneum, arthroscopic procedures, and robotic assisted procedures over traditional open surgical approaches. And I think the low pressure pneumoperitoneum deserves a shout out, because I think many of us have seen patients come to recovery after laparoscopic surgery in so much pain because of the CO2 gas in their abdomen. And that is really their only complaint, and how long it takes to get rid of that gas. So these low pressure pneumoperitoneum is a great way to minimize that. And our patients are coming into recovery in much less pain, and they're recovering a lot faster from those procedures. Now, in postoperative phase, you want to, if there's been a catheter, we want to minimize the use of catheters or drains. But if there is a catheter placed, you want to get that out as soon as possible after surgery. And then the really most important thing is to get the patients moving. Early mobilization helps to combat the well-known harmful effects linked to the extended bed rest, like heightened insulin resistance, muscle wasting, diminished lung function, hindered tissue oxygenation, increased risk of surgical site infections, and an increased likelihood of thromboembolism. So when we get our patients up, we want to get them moving. We want to encourage them to exercise post-operatively. Aerobic training and physiotherapy following surgery are safe and effective at improving health-related outcomes, and exercise has a significant effect on a patient's psychological well-being and quality of life. And then the other most important thing, lots of important things, is to reestablish oral nutrition as early as possible. So early feeding involves the reintroduction of oral or enteral nutrition within hours after surgery. So as soon as possible, this aims to accelerate the recovery process, shorten hospital stays, and reduce postoperative complications. Now, some patients will probably need a more gradual reintroduction of food, and others can tolerate eating pretty much immediately after when they're in the recovery room. And I put apples on here because I was given applesauce in the recovery room after my surgery. And pretty much as soon as I woke up, and it was divine. It was such a great food to start with to make sure that it's tolerated. Um, so it's something to think about with this early oral feeding. And then just a few patient-specific considerations. You want to think about your older adult patients. They do benefit significantly from ERAS. There's especially that preoperative optimization phase that's really good for them as well as early rehabilitation. But they're a diverse group with unique challenges, and so we want to reduce postoperative complications by making sure we're selecting them, appropriate surgery for them in their age group, and making sure they get counseling and they have risk assessments and that they're optimized. That's crucial in managing them. And in the guideline, we based that implementation strategy on the American College of Surgeons National Surgical Quality Improvement Program and the American Geriatric Society combined best practice guidelines for the perioperative care of the older adult. So you'll see that in the guideline, and some of the things that are specific to them are delirium screening up to the fifth postoperative day, um, non-pharmacologic measures for delirium, including just making sure they're oriented, they communicate with them, they're getting some stimulation, we're mobilizing them, getting them up, regulating the sleep-wake pattern, and involving relatives and other support persons that the patient trusts. And one thing that you may not be familiar with, and I'm going to talk a little bit about, is measuring troponin levels for patients who are identified to be at increased risk of cardiac events. Now, I found in the literature that more than 10 million adults worldwide have a major cardiac complication in the first 30 days after non cardiac surgery. Two-thirds of those are ischemic cardiac events or asymptomatic, and they're associated with the increase in the risk of death within 30 days. So it's very important that we're aware of this. Now, being over the age of 75, male, and with multiple comorbidities, as well as some sort of recent acute condition like high risk coronary artery disease, an aneurysm rupture, uh, a stroke, or an acute trauma like a hip fracture, or anybody that's gone through an urgent or emergent surgery, this is going to put them at greater risk. So you have got to do precise preoperative assessment of cardiac risk in these older adults. It's just a crucial thing. I think we're not aware of this very often. I don't think many facilities track postoperative cardiac events in 30 days following surgery. But we have some excellent cardiac risk calculators that can help you determine this. And measuring that troponin level following surgery is an indication of their cardiac health. Now, we recommend that these are really tricky risk assessments and that they're conducted by a physician or a surgeon who has that expertise in that field. So something to be aware of. And then ERAS and pediatrics, there is not as much research on the peds patients, but there is some, and this continues to evolve. And it's the same things that are with the adults. So you're going to do all the things that you did with adults with children, and including multimodal pain management. So something to think about with them, and that's detailed in the guideline. Now, you've got to think about your quality of program with ERAS because it's important to know your process measures because these are linked to enhanced patient outcomes. So you're going to want to track these. And they should encompass all four phases of surgical care. So your pre-admission, prehabilitation, pre-op, inter-op, and post-op. And you might measure things like what's your patient adherence to the ERAS protocol, what's your healthcare practitioner compliance with the program elements specific to the ERAS protocols by the organization, and then patient outcomes would be things like length of stay, readmission. So if you had to readmit your patient, surgical site infections, dehydration that required fluids that you want to know, mortality rate, post-operative myocardial ischemic events. And I added that because not many facilities are doing that. It might be something you might want to think about putting in your quality program. Incidence of any VTE, reduced opioid use would be an important one. Morbidity and cost per patient in the pathway. And then you could use your patient reported outcomes. That's also gives you an idea of how you can enhance clinical care and evaluate quality standards. And those are things like any symptoms reported by the patient, what's their functional status after surgery, and their overall global perception of their health. You can choose which of these you want to put in your quality program, and you don't have to track all of them, but you're going to want to track something to make sure your program is where you want it to be. And then initial and ongoing education is going to be important with ERAS, educating your teams on the importance of the program. And we provide that for you in the Center of Excellence, so we're going to go over that. But that will be really important. And then you will do some ongoing education to make sure that your teams are competent in ERAS. And then just one really quick thing, one of the most important things that I found doing the literature search was that adopting an ERAS protocol provides standardization in patient care. So it reduces variability, standardized your care. All patients are getting the same standard of care. And it aims to eliminate any unconscious biases or implicit factors that could lead to unfair outcomes. So implementing ERAS protocols can be a step toward addressing healthcare disparities and promoting more equitable outcomes with your patients, knowing that it is crucial to also actively combat overt racism and unconscious biases that contribute to perpetuating health inequalities. This is a step in the right direction. As nurses, we take care of patients every day, and it is a privilege to do so. Surgery is a stressful experience, and an ERAS program helps patients to recover faster with less complications to get back to their lives with better outcomes. So it is my hope that every hospital in this country will begin to implement this program to provide an equitable standard of care for every surgical patient. So I want to thank you for your unwavering dedication and exceptional care of perioperative patients. Your skills and compassion make a world of difference in perioperative nursing, and we always appreciate everything that you do. And now I'm going to turn our program over to Hannah Campbell, who is our program manager of the Center of Excellence. Hannah?
Thank you so much, Lisa. That's always such a fantastic presentation, especially I am not a nurse. So if those of you, I see a few of you on here that I work with already. So you all know I'm not a nurse. So that presentation always really resonates with me as a patient, right? So thank you, Lisa. And I'm excited to introduce our newest Center of Excellence in Surgical Safety Award program focused on enhanced recovery after surgery. So like our other Center of Excellence Award programs that you may have heard of, it is a complimentary education and recognition program, which we're going to talk about, and it is sponsored currently by Solventum and ConMed through the AORN Foundation. So thank you to our sponsors for making this program available to all of our nurses around the world. So real quick video that doesn't have sound, so no sound, so don't be alarmed. I'd like to play it for you all. Awesome. All right, so hopefully Lisa's presentation and kickoff of this program gets you all excited to implement your own ERAS programs at your hospitals. And I'm going to provide a program that will give you every resource you need to make that possible in your hospital. So on the screen, you'll see an overview of the program. So this particular program is evidence-based, of course, from Dr. Lisa Spruce's guideline on enhanced recovery. And it's designed to improve patients' physical and psychological conditions before, during, and after surgery. So you'll definitely want to use the program's resources to create that plan, which is tailored for every single patient during every single surgery to enhance their outcomes and speed up recovery. We'll go into each of these steps in a little bit more depth, but before we do that, I want to just share the goals and benefits of this program. So the goals are obviously to inform and equip your stakeholders and also your patients and their families with the knowledge and skills necessary to implement and participate in an ERAS program effectively. The program is also designed to provide strategies and tools to help your facilities implement ERAS programs and sustain them over time. And then last but not least, it's of course here to enhance patient recovery during every single or after every single surgery. Some of the benefits that hospitals and facilities get out of completing the program include reduced length of stay for patients. They experience faster recovery times when implementing an ERAS program. You should see lower complication rates through improved pain management and early mobilization of your patients. Enhanced patient satisfaction due to better pain control, reduced anxiety, more supportive recovery environment. And very important, I know, to a lot of our, our leadership, our COE suites, and to all of us, reducing costs, right, due to shorter hospital stays and complications. So ERAS programs have been shown to lead to significant cost savings for healthcare systems. So we have a resource, it's a business case that's available that you can use, and talking about implementing this program at your hospitals, it'll outline those cost saving benefits and then obviously the benefits to your team and to your patients. So it's a great program, and it will absolutely support a collaborative team environment, which I think is very important for not only OR teams, but every team. On the screen, you'll see the key components of what this program includes. So I know I recognize a few of you on this call. Some of you have already participated in some of AORN's other Center of Excellence programs. So that you'll be glad to know that the process for completing the program is roughly the same. So there will be an education component, which has a pre-test, education modules that take about an hour to complete in one sitting. You can complete them in 10 to 15-minute increments, but it's education based off of the guideline. So it'll all be evidence-based education with the key information from AORN's guideline for ERAS. There also will be a post-test, so we can gauge to make sure that the education was digested and your team understands it. So we have a post-test report that we'll look at to make sure your team understood and got the content down. There's a gap analysis form, which is already available to anyone who's interested in participating in the program. This is a great first step. I'll talk a little bit more about it in a couple of slides, but there's a gap analysis to help you evaluate your current ERAS practices and where there are any gaps. And then there's a compliance auditing phase, which is just a weekly observational tool to help you identify your ERAS processes and how you become compliant with the guidelines over about a 3-month period. And then last but not least, there is an application for submitting all of your materials to be considered for the Center of Excellence ERAS Award. So I'll talk about all of these in a little bit more depth. Here's a look at a sample program timeline. Many of the steps can be completed in this order. That's what makes sense for your team, but a lot of the steps can also be completed simultaneously. So depending on what works best for your team, this program is designed to operate what's going to work best for you and everyone that you work with. So let's go into each of these steps so you can determine what makes the most sense. On the screen are what we consider to be the prerequisites, right? So before you enroll in the program, you want to make sure that your leadership team, your C-suite level, they are committed to implementing this program and ERAS initiatives for all of your patients. So leadership support is very, very important because there might be some time commitment, obviously, for the education piece. And then there may be some technologies or equipment that you may need to purchase in order to ensure that you're implementing ERAS to the highest degree. So making sure that you bring this up to your leadership team, use the resources that we have available on our website to help you in those conversations. Once you have that approval, you've got universal compliance from your leadership team. Now is the time to identify the team that's going to be on the ground, who is going to see the program through from start to finish. So what we have on the screen is the facility coordinator. This is the champion of the program. So this can be you, or it can be someone maybe that's looking for leadership experience at your facility that wants to see the program through from start to finish and manage all of the components of the program. And then trickling down from there are some team members that will, of course, will support the initiative as well. It's definitely not a one-person job. It's a collaborative program. So everyone in the perioperative team will be involved, but you always want to have someone that's going to be that program manager, or what we call the facility coordinator. Next, you'll want to hold a kickoff meeting with your team. So kind of that launch meeting that will go over what is to be expected, what's coming down the pipeline, that your hospital is participating or your facility is participating in this ERAS program, and provide them the timeline, their roles and responsibilities, just overall making everyone on your team aware of the initiative. And again, the program offers all types of resources so that you're not having to create anything, really. You're using the program to implement this with your team. I mentioned earlier that gap analysis form. This is a great place to start and to work with your medical device companies. Work with your reps in using this form to figure out where any gaps may lie before you get started in the program. So this is literally just a very easy document that walks you through AORN's recommendations and whether you are fulfilling those recommendations or not. And then your medical device companies will be able to help you fill any gaps that may be existent. And then the meaty part of the program is, as mentioned, that education piece, right? So everybody has to be aware of ERAS protocols, understand the key guidelines that AORN recommends, the evidence-based research. Everybody in your team will get access to the online education platform for the program when you enroll. Really easy. Everybody has a unique login. It's just like any other online education, except for we do use some new technologies, which make it a little bit more interesting, not death by PowerPoint, if you will. So everyone will get their own access to the education platform. They'll complete their modules, which again, take about an hour to complete in one sitting, or 10 to 15-minute increments if you want to do it in bite-sized pieces. And then they'll take the post-test. Facility coordinators, so those champions of the program, will have admin access to the platform. So you'll be able to track your team, see where they are in the education component, track their post-test scores, so that you can kind of get a gauge of where your staff's at. The compliance audit tool was also mentioned as a key component. This is what we consider to be the sixth step of the program. This can be done simultaneously, though, as you are completing the education piece with your team. So as soon as you enroll, you can kick off the education with your team and also kick off the compliance audit phase if you're ready for that. It is a 3-month phase, so it's best just go ahead and get started. What we're looking for is 90% compliance on this form by that final week 12 of your auditing. It's a direct observation weekly audit. It's just an Excel document. If you're not familiar with Excel, we can help you, but it's very easy, just yes or no questions. We've designed it to be very flexible, easy for you to use, and it's a great tool to track how you're progressing week over week. Here's a look at what AORN is looking at for final recognition. So here are the criteria to apply for the Center of Excellence ERAS Award. So we mentioned the education piece. We are wanting to see 90% completion rate. So the staff that enroll in the program and are registered in the education component, we want to see 90% completion rate. Again, you'll as admins, you'll have access to track this along with AORN. We want to see an 80% or higher on the post-test. I can tell you I'm not a nurse. I've mentioned that before. I have completed this education and was able to achieve an 80% with no problem. So the education is designed to be very user-friendly and digestible content. And then that third piece, the compliance audit piece that I just mentioned, we want to see 90% compliance by week 12. So you may be at 10% compliance week 1. We don't care. We want to see that you've improved over the weeks and meet that 90% minimum compliance. All right, so here's a look at when you submit all of these materials to AORN and you're ready to be recognized and you complete everything. Here is what you receive with the Center of Excellence Enhanced Recovery Award. Every hospital will receive a custom crystal plaque to put in their facility. You'll get dedicated spot on the AORN website. So awardees get recognized on AORN's website. We provide a digital award and media kit. So we provide a sample press release, which you can plug your facility information in and use it as an HR tool or a release to your community, letting patients in your community know that you've achieved this award. And also social media assets, so things that you can post on social media, LinkedIn, and an e-signature icon with the award. And last but not least, recognition at AORN's Global Surgical Conference and Expo each year. We invite the previous year's awardees to come on stage and get recognized for earning the Center of Excellence Enhanced Recovery Award. So this is an ongoing initiative. It's not just you get the award and then you're done. It's just like any other safety initiative that should be revisited time over time to ensure that you are not falling off of the best practices, right? So the award is a 3-year designation. After 3 years upon receiving the award, AORN will touch base with you again. We'll check in to see how your protocols and processes are going. Ask you to complete one more compliance audit form just to make sure again that you're still meeting all of the ERAS guidelines. From there, you'll submit that audit, we'll take a look, and you'll be recertified for another 3 years. This is just an ongoing recertification process, again, to make sure that everyone is just staying on top of the best processes and not letting, we know over time things can fall off. It's no problem. That's why we revisit it, right? All right, so we hope after this presentation and Lisa's wonderful education about the guideline that you're ready to get started. On the screen, you'll see a QR code where you can start to begin the initial steps of this program, which will be fully available in the fall this year. So go ahead and scan that QR code. It'll take you to the program's webpage where you can download the gap analysis form, that business case that you can talk to your leadership team and say, hey, this is something I want to implement and do in our hospital, our facility. And of course, on that page, there's also access to get in touch with myself or any member of the Center of Excellence team if you have any questions. So thank you so much. We are so excited for this new program to launch this year. And now is a great time to get started so that when the full program is launched, you can just enroll and get going and get awarded at Expo next year. So at this time, we'd love to answer any questions. Feel free to pop them in the chat box. And I'll see if I can navigate to the chat box and we can answer some of those questions if there are any.
So I did try to answer some of them. Somebody asked about if we could put the slide deck in, which I think is a great resource. We can put it in the resources for the Center of Excellence ERAS page.
Yes,
Yes.
absolutely.
So you'll have the recording, but you also can get the PowerPoint if you want to use that with your, with education, with your teams. And I want to address one question about the person that asked me the question about ASCs. And I want to say this because my experience before I wrote this guideline was ERAS was only for certain surgeries. And it was surgeries that were like joint replacements and big colorectal things. And before I went through my own experience, which was in like I said at the beginning, a 4 OR ASC owned by physicians. And I thought they're going to tell me to not eat or drink after midnight. It's going to be bad. I'm not going to do it. And I was so pleasantly surprised that they had implemented everything about ERAS with all of their patients. Now, remember, most of patients that are going through an ASC and pretty minor surgeries, they are already optimized. They're pretty healthy people. So you're gonna do minimal testing with them. I think they just sort of did, they saw my history and physical from my physician, and I didn't have any testing done. That's only a small part of the program. Then it's all the other things. Are you making sure you're getting the right fasting guidelines? I was absolutely not going to go from midnight for 12 hours without drinking water. It's like, okay, no, I'm not going to do that. So if they hadn't been on board with ERAS, I was going to do my own. So that's like a specific, really important thing. Are they giving you multimodal pain? I had a block put into my arm, and then I had a pain pump. Sorry, I had a pain pump. All of those little things added up to make me have this really great recovery. So in an ASC, it's going to be a little bit less of the pre-optimization. You are going to implement everything else that you would in a hospital on the rest of those phases of care. Making sure patients are warm, making sure we've got the VTE prevention on our legs, making sure we weren't sedated, we didn't get a bunch of pain medicine. All those things are going to add up to improve that recovery. When I tell you that I recovered so completely fast and was back in the gym at 2 weeks with my arm in a brace, but working out, that was an incredible experience. So I think it's even more beneficial in an ASC because of this sort of pre-notion that these patients that they don't need it. Yes, they do. They do need it. So I just wanted to address that because I would love to discuss that with anybody that's interested in implementing it in an ASC, because I think that it can be quite beneficial for all those patients. And like I said, for me, it was all patients. Doesn't matter what the location, it doesn't matter what type of surgery, they're getting the same standard of care that is evidence-based, and they're experiencing these wonderful outcomes following surgery because not everybody does have a good outcome.
Thanks,
So I
Lisa.
just wanted to address that one.
Yeah, thank you. You might have, we touched on this a little bit, but a lot of questions we're getting are around like patient populations, and are there specific patients that should be included?
Yeah, no, it's everybody. It's absolutely everybody. I considered my shoulder surgery this minor, little thing, which it really was. Of course, I was really nervous about the pain that I was going to have afterwards. But they did all these things, like they did the ice machine, that continuous ice on your shoulder for, you take it off for just to get up to go to the bathroom, otherwise it stays on. Those little things that controlled the pain made a huge difference of not needing an opioid. And you know how opioid, we don't want to get patients reliant on opioids, and they cause so many negative side effects. And we know it's a serious problem, which is why we got the new law. So it really doesn't matter the patient population. Everybody is going to benefit from this program.
Thanks so much, Lisa. There's a lot of questions too about if you already are implementing certain aspects of ERAS. Lisa did a great job if you're not able to see the chat box, but it's the program is designed to be flexible and just to make sure that you're meeting every single aspect that is included in the guideline. Lisa, I don't know if you want to expand on that, but it's designed to be flexible, right? You don't have to, if you're already doing one part of ERAS, then of course you can skip over that part and make sure you're focusing on other areas.
Yeah, and I also want to say a lot of you had said you already have an ERAS program in place. And I offered you to be one of our beta testers. So we're looking for our early adopters who have already got experience with this to take the program and give us feedback. And if you do that, we're going to fast track you through, and we're not going to make you do everything. But here's the thing. I want to see most places that I'm experienced with, except for maybe this ASC that I was in, has it in one or two service lines. We want to see it, and that's fine. If you want to start with there, implementing it in one, we want to see you spread it to every single patient, because the goal here is to decrease variability in care and make sure every patient, no matter their procedure, is getting the same standard of care. And if you implement this with everyone, that's what you're doing. So we would love to hear from you. And Hannah, I wanted you to give your email, um,
Yep.
your COE email. And if you're interested in doing beta testing and being one of our first people, you've already got the program in place and you want to just sort of walk through the requirements, we will fast track you through and you will become one of the first centers of excellence for ERAS. So we have been looking for facilities that would be willing to do that. So if you're
Thanks.
interested, that you can email Hannah and we'll get you plugged in as soon as it opens and let you beta test it and give us feedback on what you think needs to change or how we can improve the program and be one of our first award winners.
Thanks, Lisa. Yep. And a lot of you mentioned, what's the benefit really of doing this if we already have an ERAS program? One, just making sure it's comprehensive and follows the most updated evidence-based research, right? The second is the Center of Excellence Awards are becoming nationally and internationally recognized, even from a patient standpoint level. So having that Center of Excellence Award logo next to your hospital, depending on whatever topic that you decide to complete the program for, is very important. So it's just another way to recognize your team as well for all the hard work you're doing for advanced patient care. There's a couple of questions about international participation. Absolutely. If you're in Canada, if you're anywhere in the world, you can participate in this program. The course is in English, so English is a requirement, English, being able to understand English, but absolutely anyone can participate. I see some interested beta testers, so we'll definitely reach out to those that are saying.
Yeah, Hannah,
Um,
just put your email in the chat real quick so people have
yes.
time to write it down
I answered it in the question. For some reason, I'm not able to post it in.
in the chat.
It's
Okay.
just H Campbell, my name, hcampbell@aorn.org.
So the audit tool, you can do a sample of your patients. Yes, we just want to make sure that when you see it, it's in an Excel sheet. It's real simple to use, and it's really looking at the processes. It's a process. So you want to pick, on this day, I would do it by day. I would say, okay, or this week, I'm going to do this audit tool on all the patients, or you can pick one service line to do whatever you want to do. I'm going to sort of leave it up to you and you're going to check mark that yes, you did warming. Yes, you did this. Yes, you did a pre-optimization. Yes, you had a plan in place for addressing comorbidity. So it's really simple, and it really is probably a lot of stuff you already have in place if you have an ERAS program already. But it's not going to be hard. And then we're going to take your auditing tool and just look at it to make sure that yes, you are pretty consistent with applying this evidence-based standard of care with all your patients. Or if you just have your one service line that you're going to start with, you'll do that one service line, then you're going to spread it. So we hope that by the time you do your 3-year renewal, which is basically just showing us your audit tool again, you've spread it. And we can see that you are now implementing it with more of your patients. I think Carrie on here has got 4,000 patients so far. I mean, that's what we want to see. Just get the numbers up and we're implementing it with more and more patients every day. So that's the important part.
Correct, Cheryl. So the audit tool and education have not been launched. We want to put those through a pretty rigorous beta testing situation first. We always want to make sure we have everything dialed in. So Cheryl, we'll keep an eye on the website. There are those beginning stages of the program, the beginning steps that should be completed before the audit's even done. So go ahead and head to the website and start the gap analysis form and start getting your leadership buy-in on participating in the program. Those are the great first steps. Once the audit tool and education is available, it will be live on our website, available to enroll in. Yeah, but yeah, thanks for asking. Let's see. Any other final questions? The program is complimentary, free to participate in, thanks to our sponsors, ConMed and Solventum. We do encourage you to work with your medical device companies to make sure you have everything you need for an ERAS program. That gap analysis tool is a great first start, but everything is completely free to participate in. Let's see, just
About time. It's about time.
It is. One more question. If you are currently applying ERAS protocols to only specific patient groups and not all patients, you can still apply.
Yes.
Mm-hmm.
Yes. Sure can. Okay.
All right. Well, wrapping up, my email again is in the chat box. Feel free to reach out. If you've got clinical questions, I'm happy to connect you with Dr. Lisa Spruce. Otherwise, we look forward to working with you on this important initiative in the coming months. And we hope that many of you will be our first awarded hospitals at Expo next year. So thank you so much.
Thank you, everyone. Bye.
Bye.